Good evening, senior faculty and my dear friends. Warm welcome to this PG Clinics this Friday. We have two important exam cases. One is a case of carcinoma breast, other is a case of a retroperitoneal tumor to be presented by students today. And we have very eminent faculty who have joined us today. Professor Ketan Mehta, sir, is the professor and head of the department from Mehta Medical College, Jamnagar. Thank you, Hitesh, sir, for kindly introducing Professor Mehta, sir. Warm welcome to you, sir.
Thank
And we have the honor of having Professor S.K. Tiwari, sir. He is a professor of surgery at IMS Banaras University, Varanasi, kindly recommended by Professor Ajay Khanna, sir. Thank you, sir, for joining this evening. Sir, you please drive safely. Once you reach home, you can take part in the discussion, sir. And we have the honor of having Professor Selvaraj, Professor of Surgical Oncology from Coimbatore Medical College, kindly recommended by Professor T. Srinivasan, sir. Thank you for joining, sir. And we have our senior faculty here, Professor Shanai, sir, Professor Karnakaran, sir, Dr. Rajiv Sahai, sir, and other seniors who have joined now. And the postgraduates today have been kindly contributed by the professors from Chengalpattu Medical College, Professor Arasu, and then Professor Rakesh Fernando and Professor Nirmal from Thoothukudi Medical College. So we have two important cases. We'll go for the CA breast case. We will try to finish by 45-50 minutes. Then we move on to the retroperitoneal tumor case for the day's presentation. So I warmly welcome the postgraduate to start his presentation on the CA breast. Please introduce yourself, your unit chief, your head of the department, and start your presentation. This will be by Dr. Bharat Ambarish from Government Medical College, Government Chengalpattu Medical College. Bharat, you can start your PPT. Faculty, please take over.
Good evening, sir. Good evening to all and all.
Kana, we are yet to see your
Good
PPT.
evening, sir. Sir, am I audible, sir?
You are perfectly audible, but we are unable to see your PowerPoint. Do you have any challenge, Dr. Bharat?
Sir, actually.
Now, if you have challenge, I'll ask the other boy to present first, Dr. Bharat.
Sir, I have few challenges, sir. I will present next, sir.
Okay. Faculty, kindly take note. We will move to the next case presentation first. That's the case of retroperitoneal tumor by Professor Dr. Mohammad Marsuk. He is from Government Medical College, Tuticorin. Professor Marsuk, Dr. Marsuk, are you there with us? Yes. Please introduce your unit chief, head of the department, and start your presentation. Good luck to you.
Thank you, sir. Good evening, sir. Myself, Dr. Mohammad Marzuk, the second year PG. Is a case of a retroperitoneal mass. My unit chief is Dr. Nirmal Kumar. HOD is Dr. Rakesh Fernando, sir. I'm from Government Thoothukudi Medical College, sir. Can I present, sir?
Please go ahead, ma. Please start.
Okay, sir. Sir, chief complaints, a 55-year-old gentleman, Mr. M, who is residing in Thoothukudi and is a coolie by occupation, presented with the chief complaints of mass over the left upper abdomen for the past 1 month. He also have complaints of pain over the mass for the past 3 weeks. Coming to the history of present illness, the patient was apparently normal before 1 month, after which he noticed a mass in the left upper abdomen, which was insidious in onset and gradually progressed to reach the current size, which is extending currently up to the left flank region. And he also have complaints of pain over the mass for the past 3 weeks, which is the leaking type continuous, the no aggravating and relieving factors. He also have a history of abdomen distension for the past 1 week. There is a history of significant weight loss and also loss of appetite. And he also have a history of bilateral lower limb edema. There's no history of vomiting, loose stools, constipation. There's no history of hematemesis, melena. Then there's no history of hematuria, no history of breathing difficulty, hemoptysis, no history of passing high colored urine, no history of yellowish discoloration of sclera, no history of fever, night sweats, no history of any other swelling elsewhere. He also has no history of any trauma. Past history is not a known case of any comorbid illness. It doesn't have any history of diabetic mellitus, systemic hypertension, bronchial asthma, tuberculosis, and coronary artery disease. There's no history of any radiation exposure. There's no previous any surgical histories. He has no history of any drug allergies. Personal history, he has normal bowel and bladder habits, has no sleep disturbance, is not a smoker, and the patient patient is a known alcoholic. He used to consume once in a week. There's no relevant significant family history. Summary, clinical summary. A 55-year-old male presented with complaints of swelling over the upper abdomen, left upper abdomen for the past 1 month, which is currently extending up to the left flank. We are associated with a dull aching continuous pain for the past 3 weeks with abdomen distension, loss of appetite, and significant weight loss with no relevant past and family histories. Can I proceed, sir?
Doctor, what's your, Dr. Mohammed, no? Mohammed.
Yes, sir. Yes, sir.
Just a few questions.
Okay, sir.
Small corrections.
Yes, sir.
If you don't mind, go to the first slide.
Yes, sir.
Just, yeah. So, please don't use the word coolie. Just say manager. Okay.
Okay, sir. Okay, sir.
Few soft skills you need to know whenever
Okay,
you
sir.
are in the cases. Number one.
Okay,
and
sir.
Understand mass over the left abdomen. I think better to say mass on the left side of the upper abdomen, left upper abdomen.
Okay,
There's
sir.
Small language issue. That's all right. Over the word, I think you should remove. Okay.
Okay,
mass
sir.
left upper abdomen is fine. That is
Okay,
one. And just go to the next slide. Small corrections only. Yeah.
Okay, sir.
All that is fine. Then I think you have to change that word over. That is fine. The question that 3 weeks dull aching pain, non-radiating, which specific area you asked for this radiation?
Which radiating to the back, sir?
Yeah. So one important thing, the negative point, but it is important when you say radiation, especially now left upper. Just give me 1 or 2 examples for pain in that area, radiation to the back.
Sir, in case of that any pancreatic mass, it can radiate to the back, sir.
Especially your case, left upper abdomen. So what is it? Which mass arising from pancreas? What mass?
Pseudocyst of pancreas, sir. Any
I want you to understand. Problem is in the left upper abdomen, almost like a flank. It is not on the right side. So I want the answer related to tail of the pancreas.
Okay, sir.
Tail and body, but you are talking on the left side. So pseudocyst can also occur there. Patient is alcoholic. Okay. So that is one you should know. Okay.
Yes, sir.
Anything else? Can the renal mass present like this?
Yes, sir. Renal mass can also present like this, sir.
So what questions you have asked?
Sir, I asked for that any history of any hematuria is there, sir? Any hematuria history, sir?
So we just go back a little bit before we go to others, sir.
Yes,
now,
sir.
You mentioned about aggravating and relieving factors. Any postural? Postural means, especially is they're all manual laborers, no? So any bending, anything is causing backache, all that should be inquired. Okay.
Okay, sir.
Now, why abdominal distension?
Sir, the patient has loss of weight and appetite, sir.
No, answer to that. Yeah, okay. Why abdominal distension? Yes.
That because of that, the patient is not able to take proper food. His nutritional status is also going down, sir.
So?
And so it can be any mass with a metastasis to the peritoneum also, sir.
No. Don't jump now.
Okay, sir.
This question of history of abdominal distension asked, I thought you may be right. Loss of weight and nutrition, he might have felt that mass which was growing more rapidly. You
Okay.
understand? That
Yes.
will give you a rough idea. Progress. You have written there, no? Progression.
Yes, sir.
If you
Progression.
have
Yes, sir.
significant weight loss, you will, and mass is growing.
Yes, sir.
So that may add to whatever you have said, right?
Okay, sir.
So, in the order, when you mention abdominal distension, automatically that pain, abdomen, vomiting, that should come up. So, history of abdominal distension is present
Yes, sir.
without features of
Vomiting.
obstruction.
Yes,
That
sir.
means vomiting, distension, constipation. All right. So,
Okay, sir.
my last question: bilateral lower limb edema. Why?
Sir,
Yes.
sir, here patient has any mass, sir, may compress over any vascular structure that may lead to the may compress over the IVC. Because of that, the patient may have edema, sir.
Anyway, mass is on the left flank, so we don't know. It doesn't matter. But again, that is a reasonably good answer. Plus, importantly, you said nutritional has been lost.
Nutritional.
Weight.
Yes, sir. Because of that patient.
Thank you. Please, others take over.
Other faculty can ask questions or.
Yeah. So what is your anatomical diagnosis?
Sir, from the based on the clinical history, my anatomical diagnosis, the patient having a mass in the left hypochondrium and the flank in the tumor. It can be arising from the kidneys, adrenals, and spleen, and sir.
Yeah, please.
Sir, it can be arising from the kidney, adrenals, spleen, and pancreas.
Adrenal. What is the exact location and epicenter?
Left flank region.
Which segment of the flank region? So adrenal is present at
Flank.
Top of the kidney, which is partly hidden by the causal margin. So don't give adrenal as a differential diagnosis. Whenever you give differential diagnosis, most common things would be at the first. Rare things would be at the last. So your differential diagnosis could be from the anatomical location.
Sir, it can be mass arising from the tail of the pancreas, spleen, and renal kidney. It can also from the retroperitoneal region,
especially
and also from the intestine, also colon, sir, descending colon.
Significant weight loss.
Yes, sir. Significant weight loss is there, sir.
Left colon. Yes.
Left colon malignancy, sir.
Okay, and also you gave distension.
Yes, sir.
Abdomen distension that can
yes,
be with left colon. Yes, and you said dull aching pain.
Yes, sir.
What could be the cause of the dull aching in the abdomen?
The mass is
what it signifies.
Stretching.
Dull aching type continuous pain.
Sir, and the mass is the size of the mass is huge, so is it stretching and stretching of the.
So pain will be somatic. Yes. So pain will be somatic and visceral. Visceral pain is dull colicky.
Yes,
dull aching pain is usually arising from the solid organ. Okay.
Yes,
by
sir.
ischemia or stretching of capsule like that. Okay. Any luminal pathology will produce colicky pain. So this is how you can interpret. And can he have dull aching type intermittent pain? In case of inflammation, infection,
he can have
increase. But continuous pain is usually solid organ or solid tumor. Yeah, stretching of any peritoneum or ligament, it can produce.
Okay,
And
sir.
abdomen distension, is it progressive? Is there any variation?
Yes, sir. The patient has progressive abdomen distension, sir.
What are the causes for distension of the abdomen?
Sir,
Generally?
any fluids or ascites,
Ah.
the mass itself growing and sir, and they're becoming huge, so the patient may feel his abdomen distension.
5F.
Flat as fetus, female gender, and
Pregnancy, fertile,
fertile.
fluid. Okay, so which F can be suited in this case?
Fluids.
Definitely not fertile.
Yes, sir.
Yeah. Either it should be fluid, maybe ascites. Okay.
Yes. Yes, sir.
So if the distension is intermittent, waxing and waning is present, that means colonic pathology, it can increase and decrease. But if it is due to any ascitic formation because of peritoneal metastasis, it cannot decrease in size. It will be gradually increasing in size. And if the increase in size very gradual, that might be due to solid tumor also, expansion of the volume and produces distension. Okay. And even any extraluminal compression also produced, part of the colon will be obstructed. Okay, extraluminal obstruction also can happen, but you have to elaborate finding. What about it is whether it is related to diet, fluid intake, passing urine, whether it is decreasing or not. Okay, so distension should be elaborated to rule out any colonic obstruction or bladder outlet obstruction, any other cause. It should be in an elaborate way. And what is the significant weight loss in this patient? Why you say this is significant weight loss? How do you assess?
Sir, on the 1 month,
criteria for significant weight loss?
Sir, more than 10% of these patients' weight loss in the duration of 3 months, sir, 180 days.
Okay. How many kgs in
10% of the patient body weight.
How many? What is the weight loss?
This patient had 7 kg weight loss in the 1 month itself, sir. 1 month itself, sir. The patient actual weight is 60 kg, sir.
Okay. Was there any reduced intake? Early satiety?
No early satiety, sir. The patient doesn't have any. The patient has loss of appetite, sir.
Okay. So, what is the reason for bilateral lower limb edema?
Sir, here the patient is not taking adequate nutrition, sir. Maybe because of the nutritional deficiency also, sir. The poor nourishment of the patient also. And also because of the mass is occluding over the any venous structure that may that also cause bilateral lower limb edema, sir. IVC.
Left cause bilateral limb edema.
Left side will cause unilateral, sir, due to the iliac. But here we have bilateral.
Okay. So if it is compressing the IVC, it can produce bilateral edema. Was there any other symptoms related to nutritional deficiencies?
So the patient also.
So you want to fix the limb edema to the nutritional factor. You have to give sufficient evidence for other nutritional deficiency like anemia, vitamin B complex, other nutritional deficiency should also be included in the history taking.
Okay, sir. Okay, sir.
Next slide. So hematemesis and melena. How do you correlate with this?
To rule out the mass arising from the GI, sir. In case of upper GI.
If it is, if he has hematemesis, what could be the cause for this left flank swelling?
Left flank can be from stomach also, sir.
If it is melena, I can understand.
Splenomegaly.
If it is melena, I can understand.
Can be splenomegaly. The patient have associated portal hypertension with
Yes.
esophageal varices also.
What is the name for portal hypertension caused by exclusive splenomegaly without with normal liver function?
Sir,
Yes.
Sinistral. Yes, sir.
Yes, sinistral
Portal hypertension.
portal hypertension.
Yes.
Okay, so treatment will be splenectomy.
Splenectomy.
Right, good. How do you correlate hematuria in this case?
The case is in case of the renal, if the mass is arising the renal mass, the patient may have hematuria.
What will be the triad in renal cancer?
Flank pain, hematuria, and flank mass in the flank.
Okay. So why you ask for breathing difficulty, hemoptysis?
Sir, if in case if this swelling can, if it is a malignancy, if it metastasis, no.
So lung, you want to rule out lung metastasis.
Yes, lung metastasis.
Yes. Renal cell carcinoma commonly metastasis to
lungs, sir. Patient have
lung or liver?
Renal cell carcinoma.
Why not liver?
Lung.
Liver metastasis, usually the primary should be in the territory of portal venous circulation. Okay.
Yes,
so renal kidney has no portal drainage, only systemic drainage. So commonly it will produce lung metastasis. Why high colored urine? You want to rule out any jaundice in this case?
Yes, sir, is due to rule out that liver metastasis, sir. And also, sir, if it is a pseudocyte of pancreas, also the patient that pseudocytes can compress over the bile duct and cause jaundice, sir.
So, what are all the possible sites of pseudocyst in the abdomen?
Sir, head of the pancreas, sir.
That are all common sites. It can happen at any place inside the abdomen.
Yes.
Why you ask for fever, night sweats?
Sir, if the mass is due to any lymphoproliferative disorders, the patient have fever and night sweats, sir.
Yes. Okay. And more than that, left flank swelling and fever, that is because of paraneoplastic syndrome. Fever is very common in renal cell carcinoma because of paraneoplastic syndrome. That is how you can answer this. Night sweats, it's usually related to tuberculosis, but I do not know how you can correlate tuberculosis in this case. And why trauma?
Sir, trauma because of sometimes the patient may have the swelling for the long duration. The trauma may lead to the incidental finding of the tumor, and also the retroperitoneal hematoma.
Yes, any hematoma, intramuscular or retroperitoneal hematoma can produce swelling. Yes, good. Next slide, please. What is the importance of asking diabetes mellitus in this case?
Sir, if it is a mass, if you are planning for surgery.
Yes, please tell whatever you are thinking.
Planning for surgery for a proper post-op recovery, and during that smooth intra-period and proper post-op recovery, we have that good glycemic control. So.
Okay, fine. And another important finding, chronic diabetes patient may have subclinical impending renal failure. Okay. Yes, if it's a left renal cell carcinoma,
yes, sir.
In that condition, you should consider for nephron sparing surgery.
Surgeries.
If you are going to do left nephrectomy, patient will end up in renal failure, frequent dialysis, or he may need. Yeah. So chronic diabetes mellitus, left flank swelling, you should consider in the treatment protocol for assessing the renal function, DTPA scan, and you have to assess which whether both kidneys are functioning normally. If it is subnormal or right kidney is less functioning, then consider to preserve the normal part of the kidney. So that is how surgically it is important, knowing about the baptismal test. Okay. Why radiation exposure?
Sir, in case of previous any radiation exposure for any malignancies, that is a predisposing factor for any retroperitoneal tumors.
Few carcinomas and many sarcoma can develop as a secondary cancer also, but in this site the radiation usually not happening.
Okay.
Okay, radiation will be usually pelvic organs, rectum, uterus, bladder. Okay, and for esophagus, not even for stomach.
Okay,
we are not going to give radiotherapy because the problem is any moving organ you cannot give radiotherapy.
Surrounding important vitals.
Yeah, it should be a fixed part and moving artifact. You are in scan, no?
Yes,
normal CT scan.
Yes.
So you have to deliver the particular radiation to that organ every day, 25 days in the same site. If the organ is moving, we cannot give radiation. So generally in the middle part of the abdomen, there will not be any radiotherapy given. So it is probably for the anatomical position, it is irrelevant. Okay, next slide, please. Yes. Does he has normal bowel and bladder habit?
Yes, sir.
Then how he lost 7 kg weight?
So he has reduced food intake.
In 1 month time.
He's
not able to take much diet.
Sorry, it's not
so
reduced
intake. That itself has some disturbance in the bowel habit.
Yes, sir.
And no sleep disturbance. That means he is comfortable at night, not feeling any pain at the night.
Pain is there, sir, but
so don't completion sake ask give any findings. Always go in detail with the patient. Ask more questions and elaborate and get all the details correctly. Okay. Okay. Does alcohol any relation to this site tumors?
Sir, the portal hypertension because of chronic alcoholic patient may have a liver cell failure and develop portal hypertension and splenomegaly also, sir.
Yes. Okay. Fine. Next slide. Next slide, please.
Yes.
Summarize again.
Sorry, 55-year-old male presented with complaints of swelling, complaints of mass in the left upper abdomen for the past 1 month, extending to the left flank, associated with the dull aching, continuous pain for 3 weeks with abdomen distension, with loss of appetite and significant weight loss, with no relevant past or family history, sir.
Please give your differential diagnosis. First should be the more relevant diagnosis. What could be the more relevant differential diagnosis from this summary?
Renal mass, splenomegaly,
loss of appetite, significant loss, left flank pain, mass and pain, short history, short duration of history. Which condition will produce short duration of symptoms and 7 kg weight loss?
The left sided colonic malignancy, sir, and sarcoma, retroperitoneal.
Yes. Majority of the symptoms and findings correlate with the left colon pathology. Except for colicky pain, absent of colicky pain or partial obstruction symptoms, altered bowel habits, that is not there. But even small lesion directly infiltrating the retroperitoneum without causing much obstruction can produce dull aching pain. Can you able to correlate? So pain due to retroperitoneal infiltration
From the
without luminal obstruction can produce continuous aching pain. Okay.
yes.
So
Okay.
significant weight loss not seen in renal cell carcinoma.
Carcinoma. Okay, sir.
Correct? Okay. If there is no weight loss, then I will prefer renal cell malignancy, renal pathology. But since he has significant weight loss, first diagnosis should be
Left side colonic.
left colon pathology. Second will be
Any retroperitoneal.
second will be
Any retroperitoneal.
no. By occurrence, incidence, that is rare. So you have to put the weight on the
Pancreatic.
renal
And
pancreas, renal, so anatomical differential diagnosis. Retroperitoneal tumors are by incidence is very rare, so you have to keep it. So on the retroperitoneal tumor, there is no peculiar symptoms such to you have the first differential diagnosis.
Okay, sir.
Symptom? No.
No, sir.
Okay. Yes. Please go ahead. If any other
faculty, would you like to ask
professors?
questions, Tiwari sir, Khanna sir?
Dr. Mohammed,
Yes, sir.
you are again and again telling us about the portal hypertension. Eh? So if you think the patient has got the ascites
Yes, sir.
and there is a edema is there,
Yes, sir.
which type of the portal hypertension you are thinking here?
Sinistrial portal hypertension.
Sinister portal hypertension will lead to the ascites and what is sinister portal hypertension?
Yes, sir. Because
Does
of
it lead to
the
ascites?
no.
Then
No.
which type of the portal hypertension leads to ascites? Even there may be acute ascites may be there.
Malignant portal hypertension.
No, you know what are the various etiology or types of the portal hypertension? Pre-hepatic,
Pre-hepatic,
intrahepatic,
hepatic, post-hepatic, sir. Is a bigger the post-hepatic. Pre-hepatic, sir.
in the pre-hepatic you get the ascites. Pre-hepatic the EHPBO, isn't it?
Yes, sir.
You
Extrahepatic
get the
portal.
ascites in that?
No, sir.
Is the
No, sir.
post-hepatic variety, isn't it?
Post. Okay, sir.
So what is that called as usually? What is the name of that condition? Usually.
Budd-Chiari syndrome, sir.
Yeah, Budd-Chiari syndrome.
Yes, sir.
So tell in which Budd-Chiari syndrome you will have both edema as well as the ascites. You know what are the various types of the Budd-Chiari syndromes? Suprahepatic variety, infrahepatic variety.
Yes, sir.
If it is suprahepatic variety, then you get more of the ascites as well as the edema will be there. Okay.
Yes, sir.
Now you are thinking about the left colonic malignancy. Tell what are the clinical differences between a left colon malignancy and the right colon malignancy. Only on history.
Sir, anemia will be the manifestation of the right side hepatic malignancy, sir.
Colonic malignancy.
Yes, sir. Right side.
Yeah.
Left side will be obstructive. Patient have more of obstructive.
Okay. Now, what is the difference between an altered bowel habit and alternating bowel habit?
The patient will have alternate constipation followed by diarrhea. In case of left side and chronic malignancy, sir.
Okay. And why does it occur? Why does it occur on the left side?
Sir, because of the growth is constricting nature, that the tumors are shed, and after that the patient have relief.
Now, what are the various reasons to have the alternating bowel habit on the left side? One, you said the growth is there, okay?
Growth,
The
yes,
type
sir.
of the growth which is there. It is the
Yes, sir.
infiltrative variety. What are the other reasons for that? What is the diameter of the left colon and the right colon? Which one is more?
Sir, right side is more, sir.
Right side is more. Okay. And type of the stool?
Sir, pipe stem stool. Yes.
The left and the right side. Which is more solid, which is more liquid?
Left side is more solid.
Left side is more solid. So because of these three reasons, you get this one.
Sir.
But why does it occur? If it is a narrow colon on the left side is there, if there is infiltrative growth is there, and the solid consisting of the stool is there, but why does the alternating bowel habits?
Sir, that because of the obstruction, the patient may have the obstructive symptoms for
The patient gets the constipation because of these reasons.
reasons.
So what
That,
he does?
Then after that, the straightening of the
He takes a lot of laxatives.
nose.
So he gets the what type of the loose motions are there? What is
Osmot. Osmot.
it is pseudo diarrhea. No, it is not
Yes.
a true diarrhea.
Yes, sir.
So it looks like that the patient has a diarrhea, but it is a pseudo diarrhea, not the true diarrhea.
Okay, sir.
Okay. What is a stercoral ulcer? Stercoral ulcer, yeah. Okay, what is skybella? Skybella. The skybella is a solid stool which is there. Okay. That is why sometimes when you examine this patient, you find there is a pitting type of the swelling which is there.
Okay, sir.
And that is because of those hard stools which are there. It's not the growth which you are feeling, but it is the hard stool which is there, which pits.
Okay, sir.
And this hard stool which is there, it causes the ulceration there.
Okay, sir.
And this ulceration are called as the stercoral ulcers.
Okay, sir.
And because of these ulcerations, there is a lot of mucus production is there. Okay. And because of this mucus production, that gives a pseudo diarrhea.
Yes.
Now tell, does the colonic malignancy, they metastasize to the liver, or the rectal malignancy, they metastasize to the liver?
Rectal more comparatively rectal more commonly malignant liver, sir.
Which metastasize to the chest? Lung metastasis? Colon or rectum?
Colon, sir.
Colon metastasizes to the lungs?
There's a rectum metastasis to the lungs, sir.
Yeah. Why?
The system.
Why does it metastasize to the lungs? And why the colon metastasizes to the liver?
Sir,
Also metastasizes to the liver, I'm not saying, but it is more in
portal circulation.
Yeah, on one side is the portal and another systemic.
Yes,
colon is only by the portal circulation.
Yes, sir.
Okay, that is why it goes to the liver. While there is a systemic in the rectum is there, and it can also go to the lungs. Okay.
Dr. Muhammad,
Nice, sir.
by the history, there are two conditions. One is Cox abdomen, tuberculosis, and other is hydatid disease. Can it be in differential diagnosis, and what will be the symptoms that may be in favor of both these conditions?
Sir, tuberculosis, actually the site, it's a left flank, sir. Usually the intestinal tuberculosis mostly won't present as a mass, sir. The diffuse abdomen distension will be there in intestinal tuberculosis, and the patient is for a hydatid cyst. The patient is actually the patient doesn't. The patient is not a farmer, sir, and the patient have Hydatitis cyst is most commonly occurring in the right side, actually, sir.
What will be the site of mass in tuberculosis?
RAF, sir. Right iliac fossa, sir.
And what will be frequency of a stool if there is ulcerative variety?
More than that.
Or more or less? There are three choices.
Less.
Less in ulcerative variety. That will be very high, even 30, 40, 50 times a day.
Okay.
Now, do you know what is malignant hydatid?
Yes, sir.
What is that?
It is caused by Echinococcus multilocularis, sir.
Is it a malignant condition or not?
No, sir. It is not a malignant condition, sir.
But it is called as
It's a
malignant
misnomer.
hydatid.
It's a misnomer, sir.
Right. Okay. Okay. Yeah. I think you can go now on the examination, is it? It's already 40 minutes we have passed in that, in the history.
Sir.
Yeah.
So coming to the general physical examination, the patient is thin built, poorly nourished, conscious, oriented, afebrile, hydration was fair, no dyspnea, tachypnea. Patient was pallor, no interest, clubbing, cyanosis, generalized lymphadenopathy. The patient has bilateral pitting pedal edema. ECOG is 2 for this patient. And vital examination, BP and pulse rate was normal, and saturation was 98%, and respiratory rate was 14 per minute. On examination of the abdomen, on inspection, the patient is examined in the well-lit room, and supine position, the patient is exposed from neck to the mid-thigh region. The abdomen distension is there, abdomen distended, flanks full, umbilicus flushed with surface and pushed downwards, and fullness seen in the left hypochondrium. There's no scar, dilated veins, no visible peristalsis. The bilateral hernial orifice is free, left supraclavicular fossa free, external genitalia appears normal. Palpation, there's no local rise, no warmth, no tenderness over the swelling. The mass of size 15 cross 8 centimeter present in the left hypochondrium, extending superiorly 1 centimeter below the left costal margin along the anterior axillary line. Lower border felt 5 centimeter above the anterior superior iliac spine, medially extending up to the level of mid-clavicular line, laterally up to the level of posterior axillary line. And the patient, the swelling is smooth in surface. Swelling is smooth in surface, ill-defined with a variable consistency. And the patient is able to insinuate the finger below the left costal margin. The swelling does not move with respiration, does not move in horizontal or vertical direction. Swelling is bimalony palpable. Swelling is not palatable. On knee elbow position, the swelling does not fall forward. And liver is not enlarged. Bilateral hernial orifice is free. Both testes palpable in the scrotum. Clinical picture of the patients. And percussion, and over the swelling, dull node present. Normal liver tenderness felt from the right fifth intercostal space. There is a fluid thrill present. Auscultation, bowel sounds present. Digital rectal examination, the no fissure, fistula, skin tag, sphincter tone normal, no mass or deposits felt, normal fecal staining present. Then systemic examination was unremarkable, and the spine examination is also normal. Summary, a 55-year-old male with complaints of swelling over the left upper abdomen for the past 1 month, extending to the left flank, associated with dull aching pain for the past 3 weeks, with abdomen distension for the past 1 week, with loss of appetite and significant weight loss with no relevant past or family history. On examination, mass of size 15 cross 8 centimeter, extending from the left hypochondrium to the left lumbar region, with variable consistency which does not move with respiration, and it's bimanually palpable, not palatable, not falls forward on knee elbow position, with a fluid thrill presence. Is progression diagnosis can be a case of retroperitoneal mass in the left lumbar region, probably of malignant etiology.
Mohammed, why did you tell to this patient the ECOG scale?
So to know the performance status of the patient, sir.
So you think this patient is having the malignancy?
Yes, sir. Because with the history, the patient is having the short duration swelling with the loss of weight and the loss of appetite, and abdomen distension. That ascites with the history, examination, the patient is having ascites, so more probable towards malignancy, sir.
I mean, if you're not sure about whether you are really having a case of malignancy and you want to give the performance status, it is always better, if you want to give it, it is the Karnofsky.
Karnofsky, okay, sir.
Okay, not the ECOG.
Okay, sir.
ECOG is specifically for the cancer only.
Okay, sir.
Karnofsky can be for both.
Okay, sir.
Okay. So if you are thinking you're 100% it is malignant, then definitely ECOG is good. But
Okay,
otherwise, the Karnofsky.
Okay, sir.
No, in your examination, you said only the left hypochondrium, this lump is only up to the left hypochondrium. No, just show that slide. You have just written it is probably only the left hypochondrium.
Yes, sir. Extending up to the left lumbar region also, sir.
Extending up to, have you written somewhere, Jay? I do not see that.
That word, I'm not just the extent only I wrote, sir. The lumbar region I didn't write. Sorry, sir.
You have not written that, huh?
Yes, sir. Sorry, sir.
You know how big is the left hypochondrium? What is the size of the left hypochondrium? Which you can palpate.
Fines.
It's very
Yes.
small.
Yes, sir.
You know, it will be only this much of the
Okay, sir.
left and the right hypochondrium, because majority of them is in the subcostal region.
Subcostal. Yes, sir.
Okay. Because the part of the abdomen is below the subcostal area also, so up to the diaphragm there.
Okay,
But
sir.
you cannot palpate that. So it's a very small. So even like a gallbladder lump which is there, if it is there, this will be extending to the lumbar region. So
Okay,
almost any palpable lump which is there, you have to say that it is going to the lumbar region there. No?
Okay, sir.
Okay. And then you have not told us about the liver span here. Have you told us the liver span?
No, sir. Liver dullness, normal liver dullness only told. Liver span I didn't mention. Sorry, sir.
So is there any importance of liver span?
Yes, sir. And this patient is normal only, sir. In case I happen.
What is the importance of liver span in your case?
Sir, if the patient is having any metastasis to the liver, the patient will have liver hepatomegaly, sir.
Like in terms to again coming to the portal hypertension.
The portal hypertension.
Yeah. So what is the importance of liver span?
In shrunken, it will be shrunken in case of portal hypertension.
All cases of portal hypertension will be shrunken?
No, sir. Patients have developed a cirrhosis.
Okay. If it is a hepatic variety is there, it may be shrunken.
Yes, sir.
But in which case it will be enlarged?
Sir,
Again, the same, I was asking about the
post.
Yeah, post-hepatic. Yeah.
Post-hepatic Buchiari.
There the liver may be, there may hepatomegaly may be there. Pre-hepatic, it is usually normal. EHPVO is normal. Intrahepatic variety which is there, which can be either. What are the two common intrahepatic varieties?
Sir,
Cirrhosis. And second one? What is the second cause for the intrahepatic variety? Anything like the non-cirrhotics? What is that called as?
NA is non-cirrhotic portal hypertension.
Non-cirrhotic?
Portal
hypertension called as?
NCPF.
NCPF. So what is that F?
Fibrosis.
Yeah.
Fibrosis.
So it is non-cirrhotic portal fibrosis.
Yes, portal fibrosis.
Okay. So these are the two common causes, cirrhotic and the non-cirrhotic one. No?
Yes.
Okay. All right. Yeah, anybody else can ask. Yeah.
Mohammed,
Yes,
just
sir.
go to one slide before, just
Yes, sir.
before that. Yeah. So I think somewhere you mentioned that supraclavicular and all that thing. It's better that you mention it later. Okay. Somewhere
Okay,
I don't
sir.
know. I saw somewhere, correct?
Yes, sir. Is there, sir? Yes, sir.
So inspection, go back. Yeah, I think somewhere here. So yeah, bilateral hernial orifices. Okay, you have to better make the patient stand always. I think these are some of the basics, sir. I think all of you.
Okay, sir.
Give a supraclavicular examination separately. In the lying down, you may not feel sometimes a small node there. Better
Okay,
to
sir.
make the patient stand. And
Okay,
you have
sir.
clarified about the testis.
Yes, sir.
So one of the common mistake done in sometimes women, ladies patients, women patient, you tell external genitalia normal. It is, remember, it is not. You should not do that.
Okay,
We
sir.
are not looking for anything else. This is only also is different. And then the testis in particular. Why you look for that?
Sir,
yeah.
If it is case of undescended testis, the patient may have the risk of germ cell tumors.
Okay, all
That may
right.
present as-
Or testicular tumor itself. And secondly, you have a large mass on the left side. Did you mention varicocele?
varicocele.
Particularly your patient where there's a large mass which is bimanually palpable.
Yes, sir. Palpable.
I'm not trying to say skinny or anything, but make a habit. Why should you examine particularly left varicocele?
Sir, because the left side and the testicular vein that drains directly into the renal vein perpendicularly, sir. If there is any obstruction over that, the patient may have the varicocele, sir.
So what is the best method of examination to look for varicocele?
The standing position.
So definitely you will get more credits if you are able to mention that in the test. I not only look for testicular tumor, I also look for varicocele.
Varicoceles.
According to you, it is such a large mass. There is
Okay,
a possibility. At this juncture, we don't know whether it's kidney or something. Just next slide, you mentioned about bimanual palpable. What is that? What did you do? What did you do?
Sir, based up over the swelling of both the surface, I'll keep the flexor surface up, the palm over both the swellings, sir. And
both the swelling means not both.
No, both the surface, both and upper and anterior and posterior surface, sir.
So what you have to do is, if you are obviously on the right side, your right hand will go behind, left hand. In fact, I hope you know that.
Yes, sir.
Did you make the patient sit and look for that renal space or renal angle? You are not.
Yes,
sir. Did you mention?
No, sir. Renal angle we have to see, sir. Renal angle, yes, sir.
We have to see. We have to see means you have to see. No, you should mention.
Sorry, sir. Well mentioned, sir. Because renal mass, renal fullness will be there, sir.
We are
renal angle. Renal angle.
Yeah, we are discussing something on the left side, correct?
Yes, sir.
We know that it may not be, but still, you have to mention. Especially such a large mass is there.
Yes,
bimanually palpable. We are written palatability, right?
Yes,
so
yes, sir.
What do you think? Why should the renal masses are palatable? Just this question.
Because at the pedicle, attached to the pedicle, sir, is freely moved.
One, yes. Anything else? Yes. Any pedicle organ which improves ovarian development, which happened first actually. Ovarian. Yes, internal development. Internal. This is external development. Whatever we are having. Anything else? There's a part of fat. Fat cushion.
Yes, sir.
And it's as the kidney enlarges, it enlarges more peripheral. Peripheral means side.
Okay, sir.
Back, because it's more in the retroperitoneal behind. So there is, you have got enough space.
Okay, sir.
Scientifically, what is the meaning of the word development?
Sir, we have to keep it on.
I asked you what is the meaning. I know that. What did you do?
It come and touch.
toss,
Touch.
tossing.
Toss. Okay, sir. Toss.
Head or tail.
Okay,
That
sir.
tossing. So that is some of the reasons why kidney is palatable.
Okay,
Yes, sir, somebody else can take, sir. Thank you.
Thank you.
Clinical picture, please.
Sir, ma'am.
What are the things you see?
Clinical picture.
Renal angle?
The renal fullness, dullness, sir, and tenderness, sir.
So is the renal angle dull or resonant? Normal renal angle.
Normally, it is resonant, sir, due to
Yeah.
the sir.
Due to?
colon is colonic.
And what is band of colonic resonance?
Sir, band of percuss over the renal angle. It will feel resonant note, sir.
Over the renal angle, you will percuss for the band of colonic resonance.
No, sir.
Anterior, that is, you
Anterior.
have to check anteriorly to differentiate between liver and kidney.
Okay, sir.
In
Show
how
me the
many
clinical
cases of
picture. So the abdomen is uniformly distended, correct?
Yes, sir. Uniformly distended, sir.
What is the anteroposterior diameter compared to transverse diameter in this patient?
Anteroposterior diameter is enlarged, sir.
This patient, it is more than the transverse diameter,
Transverse
uniformly distended, correct?
Yes,
So
sir.
uniformly distended, you have said 5F, correct?
Yes, sir.
What is the F present in this patient? Fluid
fluid,
thrill.
sir. Fluid thrill, sir.
Is it true? Really? I have seen the CT picture. So even though I am not able to palpate it,
Yes,
so
sir.
do you find any fluid inside the abdomen clinically?
Yes, sir. Yes, sir. Fluid is there, sir, clinically.
Not so. It should not be. It can be, and you have drawn the borders of the tumor, no?
Yes, sir. Yes, sir. On
This link movement with respiration.
Doesn't move with respiration, sir.
And you suspect movement with respiration. Which are all the tumors will have movement with respiration?
So those tumors that is attached to the diaphragm will move with respiration, sir. That is from the spleen, liver, stomach.
You are
kidney.
able to. You are able to clearly draw the upper limit, no, in this patient.
Yes, sir. Yes, sir.
Does it touch the diaphragm?
No, sir.
Then can you examine for movement
By palpating the lower.
like any pelvic tumor with upper or in the umbilical level? Will you comment on movement with respiration? So any movement with respiration, that organ should have direct or indirect contact with the diaphragm. Okay.
Yes, sir.
And how do you assess consistency in this patient?
Sir, as the patient is having that abdomen distension, we have to feel the mass with the dipping method, sir. And
See, consistency you cannot comment. Can you say consistency of the brain tumor, consistency of the lung tumor?
no, sir.
So consistency you can comment only if it is subcutaneous plane or muscle plane. It is very deep and very large one. And you can comment like soft, firm, hard. How can you differentiate variable consistency? Can you able to identify the area of soft and firm consistency in this? So that is not there. So variable inconsistency, probably retrograde finding you fit with this thing. Retroperitoneal tumor might have, sarcoma will have variable inconsistency. Because of that, don't try to fit the finding in this case. Okay. So that means you have seen know the diagnosis, you have gone through the CT finding. So you will reveal by yourself. So any intra-abdominal tumor consistency is approximate. That can be firm, hard. Even you cannot comment as soft inconsistency in intra-abdominal tumors,
Okay,
right?
sir. Okay, sir.
And what is the renal angle normally has?
Sir, it's between the 12th rib and the
Its structure
appendage.
present normally, renal angle.
Colon.
Name is renal angle, but content will be left colon.
Left colon.
Correct?
Yes, sir.
Or right colon. Colon is the occupying organ. So, if you say retroperitoneal tumor is to check the. Did you check?
Sir, sorry, sir, not. Sir.
You renal angle dullness.
Yes, I didn't check. Sir.
What is the finding in this patient?
The renal angle is free only. No fullness in this sense.
So no dullness. It is resonant.
No dullness.
You are saying
yes, sir,
renal angle is resonant. That is wrong. I will explain in the CT scan. Okay. So I will explain the absence of fluid and absence of renal angle resonance in this case.
Sir.
Okay.
Sir.
Right.
Sir, sorry, sir. Sorry, sir. First time that patient initially they have a complaint of 1 month, sir. The CT was taken during the initial period, sir. That time the patient doesn't have the complaints of abdomen distension, sir. So this abdomen distension is after some 2 weeks of the swelling only the patient has this abdomen distension, sir. So that time CT was taken initially, sir. First time. So the CT also there was no ascites and that CT while taking CT, sir.
Okay. Fine. Ascites you can explain like this, but renal angle dullness must be there because entire left colon pushed to the midline because of retroperitoneal growth. I have seen in the CT scan. When you show the CT scan, I will explain. Okay.
Okay.
Do you think all the renal tumors are palatable? 5 centimeter, 50 centimeter, 30 centimeter tumor is palatable?
No, sir.
So palatable, for palatability, you have to have a free renal tumor without infiltration. If it is infiltrating retroperitoneally, you cannot palat.
Okay,
right?
Sir.
And the tumor is very big, already touches and distance the anterior abdominal wall. You should not elicit at all. It is illogical to try to elicit palatability. When you are able to see some tumor is pushing the anterior abdominal wall already, you should not try to elicit at all. It is illogical, right? Correct? Okay. So it should not touch the anterior abdominal wall. Then you can try to palat.
Okay, sir.
Correct. So movement with respiration, it is irrelevant at this site. You need not to comment on palatability for any distending tumors. And consistency, very cautious. You can comment only firm in consistency or hard in consistency. No soft or fluid cystic nature of this thing. You cannot comment any intra-abdominal tumors, right?
Okay. Okay.
Please. So you don't have differential diagnosis of renal tumor?
Sir, we can't tell, sir, if there is a renal tumor with infiltration into the retroperitoneum.
That is what I am asking. You cannot tell anything at this stage. You can give only differential diagnosis.
Differential diagnosis.
It's a very rare diagnosis. Don't always try to give differential diagnosis. And if you say if it is a renal tumor, second differential diagnosis is retroperitoneal tumor, I can accept.
Okay, sir.
Okay. If you say renal tumor and it is very big, that is no palatability. Tumor 10 to 20% will have urea. Not very common symptom. Okay.
Yes.
So renal locally renal second
Okay.
And third event, colon
Thank you.
malignancy with peritoneal
Colon-
metastasis
Yes, sir.
causing ascites and
Okay,
limb edema because of nutritional deficiency, weight loss. So you can fit everything in colonic malignancy also, except for colic in absence of spurious. Okay.
Yes, sir.
So it is not a clear-cut case. You can offer 3 differential diagnoses. First, my preference will be renal mass, locally advanced or metastatic renal mass, then retroperitoneal sarcoma and colonic malignancy. Okay. Please go ahead with management.
Sir, I will proceed.
I had a query.
Yes,
Yeah.
ma'am.
You in the history said that the mass started in the upper part of the abdomen and progressed to the flank.
Yes, ma'am.
And now on examination, we find that it's a retroperitoneal mass. And on top of that, patient has loss of weight and loss of appetite. Do you think it could be a mass lesion arising from the tail of pancreas?
It can
Which
be,
could
ma'am.
be a large cyst also and should be kept as a first diagnosis because everything fits into it in the sense that weight loss, a retroperitoneal mass, the site fits into it. They may be associated with ascites and they can also have because of thrombus, say, in the splenic vein and the portal vein that has gone on to the hepatic veins as a bud Chiari with acute onset of ascites. So to my mind, I think it should be an important differential diagnosis. And then what about GIST?
GST can be also there, ma'am, but
So I felt these are two things which must be kept in mind.
okay, ma'am.
Please take over, sir. Thank you.
With the presence of fluid thrill, also you cannot comment consistency. Am I correct?
Yes, sir.
Yeah.
Well,
So
welcome.
when there is a fluid, intervening fluid, you cannot comment on the consistency. Okay. Just clarification. Please proceed.
Mohammed, just only one question. If there is a fluid thrill or fluid is present, if you, according to you, ascites is present, correct, no?
Yes, sir.
The sir has given you some diagnosis, out of which one probably you will favor, if your finding is correct. How common is to get fluid in retroperitoneal tumors or sarcomas? First question.
Sir, it's rare, sir. Non-neoplastic non-malignant ascites is, sir. It's one of the finding, but it is a very rare finding in case of retroperitoneal
It has
sarcomas.
not come to very, very rare things happening and all. 1 month duration, short duration. Second, how common in renal cell carcinoma?
Renal cell carcinoma, so it's rare, sir. It's a more common in case of a colonic malignancy, sir.
No, what we are trying to tell is it should be something which has caused some peritoneal seedling or
metastasis.
Keeping that in mind, where do you put your bet now? Let us put it that way. Where do you put the bet? No, I'm just asking you. After ruling out that 1 and 2, so you put the bet in again colon and pancreas, correct?
Yes, sir.
Now, what is that absolutely missing in your patient for such a big mass if you suspect a colon?
Sir, alternating bowel and bladder habits history is there, sir.
Left side, no, left side splenic flexure, that area, whatever it is, whatever said and done. So less like. So like that, we have to try to eliminate one by one. So when a large masses are there, sometimes histological surprises are there, but you should keep it in mind, common things.
Okay, sir.
No rule that pancreas should always have bracket. More of them sometimes they expand anteriorly. There is no rule that kidney you should be able to be bimanually palpable. More if it occurs in the more it goes anteriorly, you will not be able to get it.
Okay, sir.
As someone pointed out, it is very close to the abdomen. It enlarges more posteriorly. So you have got a place to keep your hand anteriorly and ballot from behind. In your case, it's more anterior. Renal angle is absolutely free, correct?
Yes, sir.
So in other words, you should be able to explain the examination. So this is how it is, this is how it is, this is how it is. So at the lastly, you don't consider spleen at all. I'm just asking you.
Yes, sir. Spleen.
Spleen.
Spleen. Yes, sir. Is able to insinuate the finger above the swelling and the.
No, 1 minute. Clarify what you mean by insinuation over trying to get above. If you have a dome, think of a dome. You understand what I'm telling? Think of a dome. You
Yes,
put
sir.
your hand above like this. That doesn't mean you're insinuating. Is it clear to you what I got the point?
Yes, sir.
So it doesn't move. No.
Okay, sir.
Heart is not moving with respiration.
Yes, sir. Not both is respirations.
Practically, notch is not there, so you are ruled out spleen. Okay, that's how we will say. So these are the few differences. Okay, sir. Thank you. Go to the
Sir, initially I'll proceed with the ultrasound, sir. Initial radiological investigation ultrasound. Use the abdominal pelvis to look for the exact site of origin of the tumor. And next line is like a CCT abdominal pelvis. Sir, then sir, even if the diagnosis is inconclusive, we have to go for the guided procedures for histopathological information, sir.
Proceed.
Sir. First is that ultrasonogram, sir, to look for the site of origin and the nature of the swelling, whether it's a cystic or solid, and how long it's extending, and what are the different any component. Next is the CCT abdominal pelvis to look for the same, look for the extent and surrounding invasion to the adjoint structures. Sir. Sir, am I audible, sir?
Has the been done in this patient?
Yes, sir. Ultrasonogram done, sir.
Yeah. Just show us the picture or the report, whatever it is.
Yes, sir. Sir, initial USG is also a large heterogeneous mass, 20.5 across 15 centimeter in the left lumbar region, and impression that they told that it's a Cori retroperitoneal mass, sir. It's the initial ultrasound, sir. We are not. Then we proceeded with the CT, sir.
Okay.
And CT shows the large heterogeneously engaging soft tissue dense lesion, 90 cross 8 cross 15 cross 0.6 cross 10 centimeter in the retroperitoneal region, lateral to the left kidney, displacing it. And here the
always any imaging save with the date. Already you told this is one month earlier done, no?
Okay, sir. Okay, sir. Hereafter I will do this, sir.
Always, whenever you see any imaging, always correlate with the date.
Okay,
probably
sir.
old image.
Okay, sir. And
next slide.
Yes, sir. Yes, sir. Next we proceeded with here they give that the fat planes between the left kidney and the lesion was not well defined, sir. So the impression is that retroperitoneal left perinephric sarcoma.
Show me the picture. Show me the picture. Next one. All cuts.
Yes, sir.
Next one.
These two pictures.
Next one. Yes. See, you can see the you can see the left colon pushed by the tumor.
Yes,
are you able to see the shadow?
Yes, sir.
Yeah, that is, yeah.
Yes,
so sir. How can the renal angle will be resonant?
Sorry,
correct?
Yes, sir.
No cook-up findings. Yes, next slide.
Sir, next we proceeded with the
with the coronal cuts. See
Yes, sir.
picture with coronal cut.
Yes, sir.
Next one. Next one. Another one.
Then we proceeded
One
with the
more
MRI.
fine picture with go behind last CT image.
So this one, sir, is MRI, sir, plain MRI abdominal pelvis.
Yeah, see, there left abdomen is filled. And next slide. Yeah, see the
Yes,
coronal cut. See, it is extending from the spleen, lower part of the spleen to the. Show me the picture. MRI, probably MRI.
Yes, sir. This one, sir.
Picture, not report.
Yes, sir.
This is report. Yeah, this one.
Yes, sir.
Correct. See, entire hemi-abdomen filled with tumor. Okay.
Okay, sir.
So, obviously, because of the compression itself, mass effect will produce loss of appetite, inability to take diet, reduced diet, and later on, probably peritoneal metastasis, extension into the peritoneum produces ascites or hypoproteinemia induced ascites with bilateral pleural edema. You can correlate all the findings from these pictures.
Okay.
Yes, proceed.
Sir, next we proceeded with MRI abdominal pelvis, which showed a large, well-defined heterogeneous hyperintense solid mass on T1 weight image. In the left half of the abdomen arising from the retroperitoneum, causing displacement of the retroperitoneal structure. That here in the transitional zone between the mass and the left kidney was maintained, and it gave the impression as a retroperitoneal sarcoma.
MRI done 1 month back.
Sir, 2 weeks after 2 weeks, sir. After 2 weeks, sir.
Before developing ascites.
Sir, before developing ascites, sir. In MRI also there was a mild ascites they gave, sir.
Okay, so now it is gross.
Yes, sir. Now it is gross, sir.
Gross ascites is there now, correct?
Yes, sir. Yes, sir.
Because flanks are full.
Yes, sir.
Okay, patient is emaciated. You just put the clinical picture. Show the clinical picture. I'll describe the abdomen.
I'm
Show
sorry
the
to
clinical
interrupt.
picture.
Sorry to interrupt. Esteemed faculty, it's much longer than the permitted time. I understand it's a long case, but then I would request you to give a diagnosis and finish the discussion in 5 minutes because we have one more case to complete discussion, please. Kind request.
Yes, sure. So gross distension seen by emaciated patient. The abdomen is lifted above the level of costal margin. Flanks are full. So obviously this must be ascites by inspection itself. Right. Good. Management. How do you manage this patient?
Sir, we'll go for the surgical surgery is the mainstay of treatment for this patient.
Surgery for this patient.
No, sir.
Before you think that you can go for the surgery of this,
biopsy.
Did you
Sir,
check?
Yes, sir. Usually, we went for image guided biopsy, sir. Core-needle biopsy. Usually, get a core-needle biopsy done, which shows finding suggestive of spindle cell sarcoma with the area of necrosis, sir.
Is it operable by imaging and clinical findings?
No, sir. It is inoperable, sir.
If it is a liposarcoma, it is operable. Okay.
Yes, sir.
Even 90% of the abdomen filled with liposarcoma, but it has good prognosis. So you can do 3-4 times resection with surgical morbidity alone. Patient will be alive. But apart from liposarcoma, other sarcoma, it is very difficult to operate because of the infiltrative pattern, and it already engulfs the kidney, left kidney. Obviously, if you are proceeding it with, you have to do nephrectomy also. So complete clearance is very difficult in this patient.
Okay. Yes, sir.
So symptomatic care, I would suggest this is a locally advanced, probably with peritoneal metastasis, incurable disease. So best supportive care is adequate. And for doing any imaging, if you find any metastatic disease in the ultrasound, don't prescribe CT scan.
Okay, sir.
If you see liver metastasis and colon malignancy in the ultrasound, don't prescribe CT scan. No need for that.
Okay, sir.
You will not get any additional information from doing imaging in palliative settings. Okay.
Okay.
Right.
Okay, sir.
I think we can proceed with the next case. Thank you.
1 second, Tiwari sir, Mehta sir, would you have any questions or comments, sir? I understand we have a lot to discuss, but then in the interest of the next candidate, we have to close this page.
I will have a question in CABRES case, sir.
Sure, sir. Sure. Tiwari
Thank
sir.
you.
Yes. So this case important is tissue diagnosis, and that should be emphasized. So which type of biopsy should be done? It is still, so that should be image guided biopsy.
Image guided biopsy.
If we are using core radial biopsy, that should be USG guided, better.
Yes, sir.
So that representative area should be taken. So you must remember, because 10 years back, probably that was just core needle biopsy, but now that should be image guided. Thanks.
Any questions from you, Dr. Marsuk? Any doubts or any questions?
Sir, here in this case, sir, because that clinically, that MRI wise, they told that the fat lines between the kidney and the mass is well maintained. Usually, the sarcomas used to compress the other structures. It usually won't infiltrate the other structures. So, can we proceed with the resection alone, or we have to go for nephrectomy?
Mohammed, just I want to come here at this stage. Vast majority, more than 60% retroperitoneal sarcomas arising from the perinephric
fat. Yes, sir. Perinephric fat, sir.
In other words, if possible to save the kidney, you should save the kidney. So, if possible, please remember, we will not be able to get probably a R0 resection. Please read about that.
Yes, sir.
Only issue in your case is that ascites, which is totally usually uncommon.
Sir, we did tapping of the ascites, sir, in that cytological journal. It came as a no malignant cells in the ascites.
Because I don't expect 1 month retroperitoneal sarcoma to go to the peritoneal cavity. We have seen plenty of them, not one or two, plenty of them.
Okay, sir.
Much bigger than this size also. So, in other words, anyway, these are some of the points. There's a lot of controversies here, including role of FNAC. This kind of a new, but your patient has got ascites. You suspect it's inoperable, then the issues of tissue diagnosis will come, or doubt, lymphoma, or recurrence, or involving the paravertebral tissues, muscles, and major vessel.
Yes, sir.
Most of them land with a multivisceral resection. Multivisceral means including this. Tail of the pancreas may go here. Sometimes, see, all that location that makes it like that. I think time is short. Kanakvel, I will stop here. That's all.
Thank you, sir.
Thank you, sir. Kanna sir, anyone else would I like to add, or we move to the next case, sir?
We can go to the next case. It's already 9:30.
Yes,
yeah.
Sir. Thank you, Marsuk. You can
Thank you,
stay
sir.
back. I'm sure your case has evoked a lot of discussion, but then you also can stay with the next case discussion, which
Okay,
Dr. Bharat Ambrish is going to present. Dr.
Okay,
Bharat is again a
you,
postgraduate from Government Chengalpattu Medical College, kindly contributed by Professor B.T. Arasu, sir, the head of the Department of General Surgery. Dr. Bharat, please introduce yourself, your chief, and then you start your presentation. Good luck to you.
Good evening, sirs. I am Dr. Bharat Ambrish from Chengalpattu Medical College. I am a postgraduate in general surgery. I am here to present a case of breast lump under the guidance of our HOD, sir, Professor Dr. V.T. Arasu, sir. And once again, thank you to the opportunity. Now I am going to the case. So here, a 46-year-old female, Mrs. Girija, homemaker by occupation, coming from Marudharanagam, presented to the OP with complaints of lump in the right breast since past 1.5 months. So history of presenting illness, the patient was apparently normal for before 1.5 months, after which she noticed a lump in the right breast, which was insidious in onset, progressive in nature, not associated with pain, not associated with any ulceration or discharge. So no history of any nipple discharge, no history of any recent interaction of nipple, no history of any other lump in the same breast or contralateral breast or axilla, no history of significant weight loss of around 6 kgs in the past month, no history of loss of appetite, no history of any trauma, no history of any bone pain, no history of any low back ache, no history of breathing difficulty, cough or pneumocystis, no history of abdominal pain or jaundice, no history of headache, blackouts or convulsions. Comorbidity history. The patient is not a known case of type 2 diabetes mellitus, systemic hypertension, bronchial asthma, tuberculosis, epilepsy, cardiac disorders, or thyroid disorders. Past history. Patient had no history of similar complaints in the past. History of biopsy taken from the lump in the right breast 10 days back. No other history of surgeries in the past. No history of radiation exposure in the childhood. No history of oral contraceptive pills intake. Menstrual history and obstetric history. Patient attained menarche at 13 years of age, attained menopause 2 years back. She got married at 20 years of age and she was nulliparous. Family history, no history of any breast or ovarian cancer in the first or second degree relatives. No history of any malignancy in the family members. Personal history, patient takes a mixed diet, normal bowel and bladder habits, no history of loss of appetite, history of loss of weight of about 6 kgs over the past month, no history of sleep disturbances, no history of any other allergies. Summary, a 47 years old female, nulliparous woman, Mrs. Girija, with the complaints of painless lump in the right breast since 1.5 months, with history of significant loss of weight, with no other significant history.
Sir, good evening, everyone, sir. Sir, I think I regularly, because I am talking to them, I will join with the discussion and questioning, sir. Anybody can take the lead and ask them, sir. This is my suggestion. I just felt he'll be exposed to all your questioning and discussion, sir. Is it right, sir?
Perfectly fine, sir. Let them go. Let the faculty take over.
Yes, sir. Yes, sir.
Mehta, sir. Selvaraj, sir.
Yes, sir. He can complete.
Bharat, in your chief complaint, you're writing lump in the right breast. No, go to the first slide.
Yes, sir.
Yeah. Since 1.5 months.
Yes, sir.
Is that the correct thing?
No, sir. Patient actually noticed the breast lump for past 1.5 months.
Since is a good word? Here?
No, sir.
So what you should write?
Patient noticed a lump in the right breast.
Since or far?
For last 1 month.
Yeah. So say far 1.5 months, most likely. No? Rather than saying the since, say it far. Okay, go to the next slide.
Yes, sir.
Next slide. The patient was apparently remain on that side.
Yes.
Stay on that slide.
Yes, sir.
The patient was apparently normal 1.5 months back, after which she noticed a lump in the right breast. Is it okay?
So the patient actually noticed the lump on the right breast 1.5 months back. She might have had a lump before that also.
No, but that is not a good one. No? This language is not good. After which she noticed a lump in the right breast. No? Okay, she has noticed a lump there for 1.5 months. No? Okay. So that is not a good language to be used. Okay. Go to the next slide. Your slides have disappeared. Can you again share your slides? Yeah.
I will share it.
Okay. Go to the next one.
Yes.
Okay. Go next one. Now, specifically, what are the various risk factors you have asked in your history there in this patient?
Sir, actually, I got the history regarding the lump, sir, and its local regional complications. like discharge or any retraction of nipples, like the local regional complication, and systemic complications like any loss of weight or loss of appetite.
I'm
And
asking,
I asked for,
Bharat, I'm asking you, what are
yes,
the
sir.
various risk factors
Yes,
you have asked in your history?
yes. Sir, yes, factors. I have asked for
Bharat,
yes, sir.
Bharat,
Yes, sir.
what are the risk factors or predisposing factors for malignancy, which you have
Yes, sir.
asked is the question. The
Yes, sir. I
question
have
is,
asked, sir. I have asked regarding the obstetric history, sir, whether
yes.
a patient is nulliparous or and whether she had early menarche or late menopause. Apparently here the patient is nulliparous, sir. So that is a risk factor here. And I have asked in the past history whether there is any intake of OCPs or hormonal therapy, sir. That was a risk factor for the patient, sir.
And what other history? Any other predisposition? What are the predispositions?
Here the patient is nulliparous, sir. That's a predisposing agent.
Other than that,
Patient didn't had any breastfeeding, didn't undergone any breastfeeding. That's a risk factor, sir.
Other than that,
Other than
the
that,
menstrual
age.
Is it a family history in any way? Is it relevant in the case of breast cancer?
It's a previous history of breast cancer in the families or in either malignancies mainly.
Why should it be important? Why should it be important?
Sir, BRCA1 and BRCA2 mutations may be present in the familial breast cancers.
What is the incidence combinedly BRCA1 and 2 together can cause breast cancer? Which percentage of women can have BRCA1 or BRCA2 as a risk factor overall?
20 to 30% there is a risk
exactly. There is still 70% of breast cancers which is there, which is not associated with BRCA. Sir, what are the other risk factors? Genetically.
Genetically, patient may have any P53 mutations.
What is that? What is that?
P53 is a tumor productive gene, on-to-productive gene.
Okay. What other cancer can be associated in P53 or tumor suppressor gene mutation?
Colonic cancer.
No, sarcoma and leukemias. What is Cowden syndrome?
P10 mutation.
Yes. It can be associated with thyroid cancer and colonic cancer and colonic polyps. Okay. Right. Otherwise, without anything, in some of the families, patients may be genetically predisposed without any syndromic manifestation. What is the relationship of obesity, alcohol intake, and sedentary
alcohol intake increases the risk of breast cancer, sir.
How?
And obesity will cause alcohol intake will decrease the metabolism of estrogen, and there will be increased estrogen in the body, sir. So
the peripheral fat, it will promote the conversion of steroids.
Steroids, testosterone to
steroid hormones, and steroid is okay. You said nulliparity or early menarche, late menopause is a risk factor. How and why?
Sir, early menarche, the breast is exposed to more hormones, sir. Once menarche starts, the breast is constantly exposed to estrogen and progesterone, so there is an increased risk of breast cancer. And delayed menopause, sir.
Okay, proceed.
In delayed menopause also, the patient is increasingly exposed to the hormones, estrogen, progesterone.
Okay. Which hormone is predisposed high to incidence of cancer? Estrogen or progesterone? Estrogen. So unopposed action of estrogen. So late pregnancy is a risk factor. Okay. Right, I think. Okay, sir. Is there any chance for irradiation to produce breast cancer?
Yes, sir. Irradiation to Hodgkin's lymphomas to the chest may lead to breast cancer.
Okay.
Any chest irradiation, yes, sir.
Any method of phytogenic method by which in a country like India, breast cancer can be predisposed? Sometimes indiscriminate use of digital mammograms in younger women, they can go and have without any doctor's prescription, can dispose predisposed to women. It is not. Sometimes it is done. They go on doing it every year, 30, 35 years. It increases the chances. So it must be done with caution. Thank you, sir. Okay, sir. Just wanted him to kindle him out, sir. Thank you, sir. Sir, please join, sir.
Bharat, you asked about any surgical history in this patient. What was the surgical history you were interested?
Sir, any previous mastectomies patient has undergone or any breast conservative surgeries, there may be a recurrence of tumor.
Any benign condition which can lead to malignancy?
Ductal carcinoma, lobular carcinoma, and
benign condition.
Benign condition.
Ductal papillomas and fibroadenoma may rarely lead to malignancy.
Okay. Fibroadenoma may
rarely lead to malignancy.
No, we operate left and right fibroadenoma, but they never develop the malignancy, until unless it's a giant fibro, I don't know. Any benign nodular disease, what is called as? Have you heard the name of ADH? Atypical ductal hyperplasia?
Yes, atypical ductal hyperplasia.
Yeah, atypical ductal hyperplasia. That is a, so there are very few absolute risk factors for the breast cancer.
Yes, sir.
And absolute risk factors are the age of the patient, family history of the breast cancer is there, the patient herself had suffered from one side breast cancer, past history of atypical ductal hyperplasia is there, or BRCA1, BRCA2 is positive. So these are the only absolute risk factors, while all others which are there, nulliparity, early menarche, late menopause, drinking, smoking, obesity, HRT, OCPs, they are all just the relative risk factors. Okay. Right. Yeah, you can now go to the examination part.
Just Bharat, one question. What about dietary risk factors?
Dietary risk factors, only food habits may leading to increased obesity, cause unsaturated fatty acids may lead to increased risk of breast cancer.
Protective diet?
Sir?
Protective diet in carcinoma breast?
High fiber diets. High fiber diet and alpha linolenic acid.
Hello.
Okay, proceed.
Yes, Bharat.
Yes. General examination, patient is conscious, well-oriented, moderately built and moderately nourished. ECOG, patient has an ECOG score of 0. Hydration was fair. Patient doesn't have any parallel icterus or cyanosis. No pedal edema, generalized lymphadenopathia, or clumping. So vitals of the patient, blood pressure of the patient is 110/80 mm of mercury, measured in left upper arm in sitting posture, and the pulse rate is 76 beats per minute, regular in rhythm, normal in volume, and character and vessel wall appearance are normal. Is normal, temperature of 98 degrees Fahrenheit, and respiratory rate of 14 cycles per minute. So examining the breast, after obtaining the consent from the patient is exposed from above to the waist. The patient is examined in the sitting position, arms by the side in the well-lit room. So asymmetry of the breast is noted. The right breast appears larger than the left. Right nipple appears pushed outwards and downwards compared to the left nipple. A swelling of size 4x4 centimeters noted in the upper inner and upper outer quadrant of the right breast. Still over the swelling as a needle biopsy mark seen. No dilated veins, no ulcer, puree orange or nodules noted in the skin. So this is the clinical image of the patient. And the right nipple area complex, the nipple appears pushed outwards and downwards as compared to the left nipple. No retraction noted in the nipple, no erythema or ulcer. No other visible lumps or fullness in the right breast. The left breast appears normal. And arms, inspecting while the patient arms raised above the head, no axillary fullness, no dimpling or skin changes seen over the lump. Inframammary fold was normal. On bending forward, both the breast falls freely forward equally. Right supraclavicular fossa, no fullness, and right arm appears normal. So on palpation, there was no warmth, no tenderness. Single swelling of size 4 cross 4 centimeter in the right upper and inner quadrant and the upper outer quadrant of the breast at 11 o'clock to 1 o'clock position. Shape was spherical in shape and with uneven surfaces, well-defined borders, hard in consistency, and it moves
Is
along
it
with the
upper
breast
outer
tissue.
quadrant or upper inner quadrant?
So predominantly in upper inner quadrant, sir, but the swelling was also in upper outer quadrant.
Then what will you say? It is in the upper inner quadrant extending to the upper outer
To the
quadrant.
upper outer quadrant. Yes.
By seeing the photograph, it never
Yes.
it is not crossing the nipple line. So it is
Yes.
upper inner quadrant.
Upper inner quadrant. Yes.
Because it is very important, upper inner quadrant reconstruction in breast conservation surgery is very difficult, technically demanding.
Yes.
Okay, young patient may prefer breast conservation surgery. So you cannot say upper outer quadrant. Upper outer quadrant very easy to reconstruct, but inner quadrant always the technical difficulty will be there. Okay, proceed.
Next, skin over the swelling was free. On contracting the pectoralis major muscle, there is no restriction of mobility either along or perpendicular to the direction of fibers. Palpation of the nipple areolar complex was normal. The examination of right axilla, a single discrete anterior.
Which mobility is important when you contract? When you contract, which mobility is important? Across the muscle fiber or along the muscle fiber?
Across the muscle fiber.
Which is important?
Which is important.
See, you can imagine the bow and arrow. The string of the bow can be moved, even though it is tense. So across the mobility is not important. Along the muscle direction of the muscle is very important. Okay. Right.
The examination of right axilla, a single discrete anterior group of lymph node of size 2 cross 2 centimeters, non-tender, hard in consistency, and a mobile node. Another single discrete central group of node of size 2 cross 2 centimeters, non-tender, hard in consistency, and mobile. Examination of left breast and axilla, no abnormality detected. Percussion over the parasternal region, no dullness noted. Supraclavicular fossa, no lymphadenopathy noted. Right arm, no swelling or edema.
Don't jump between percussion and palpation.
Complete palpation, one by region wise.
Small mistakes, but doesn't look nice.
Systemic examination. Spine examination, no spinal or paraspinal tenderness.
No. Complete your nodal examination clearly and then go proceed. Why should you be hurrying, man? Presentation, they have not seen the case.
We are not in hurry. Why are you hurrying?
Thank you, sir. Thank you.
Sir, an examination of the right axilla, a single discrete anterior group of lymph node of size 2 cross 2 centimeters, non-tender, hard in consistency, and a mobile node. Another single discrete central group of node of size 2 cross 2 centimeters, non-tender, hard in consistency, and mobile. The examination of the left breast and axilla, no abnormalities were detected. And on palpation of the supraclavicular fossa, no lymph nodes was noted. And on palpation of the right arm, there was no swelling or edema. And percussion over the parasternal region, there is no dullness noted.
Why do you examine the opposite breast? Why do you examine the opposite breast?
Metasynchronic, whether there is any synchronous lesion over there in the opposite breast.
So risk factor is same for the both breast and so synchronous or metastatic. It is present in the medial aspect, no? So even breast to breast metastasis can happen. Inner quadrant to inner quadrant. Yes, good.
Systemic examinations. On examining spine, there was no spinal or paraspinal tenderness. On cardiovascular system, S1, S2 was heard. On respiratory system, the bilateral arrhythmia was equal. And central nervous system, no focal neurological deficits were seen. Periabdominal examination was soft, no hepatomegaly, no palpable masses were seen. And perivaginal examination was normal. Perirectal examination was normal.
What do you expect in parectal examination in CA breast?
Perirectal, whether there is any lumbar shelf.
Yes, good.
Probably.
Which other lymph node you should tell apart from the axillary lymph node? You have examined the supraclavicular nodes. You have looked for the parasternal dullness. Which other lymph node you should examine there? Anything below the clavicle?
Apical. Sir is asking about infraclavicular.
That is the axillary node.
Infraclavicular.
Infraclavicular. You know? You should also tell about the infraclavicular lymph nodes also. Now, is your tumor fixed to the chest wall or not?
No, sir.
How do you say it is not fixed to the chest wall?
Tumor was freely mobile, sir.
Okay, but in any lump which is there, how do you say that this tumor is fixed to the chest wall?
What examination you will do to say that the tumor is fixed to the chest wall or not is the question.
Serratus anterior.
Yeah, how will you check? Yeah.
Ask the patient to push against the wall and look for mobility of the swellings.
Okay.
So whole of the breast lies over
Which quadrant swelling you will do serratus anterior? Which quadrant swelling tends to
lower inner quadrants?
Yes.
Outer
This swelling will
lower
not
inner or lower outer?
Lower outer.
Outer.
So suppose if sir answer the question of sir, here what constitutes a chest wall in this juncture, in this mass, which is a chest wall?
Chest wall is ribs and pectoralis minor.
Pectoralis minor is not. No, you are making a mistake. Yeah. Ribs and intercostal muscle. Intercostal muscles.
Intercostal muscles are and sternum are chest wall.
Bone, yes.
So how will you say that? That this lump is fixed to the chest wall? You still not have answered that. If this lump is not mobile, this is fixed to the chest.
It's mobile.
Except the area of the serratus anterior, which is there. If a lump is not mobile, it is fixed to the chest wall. Right? Only except for the serratus anterior area. Could you understand that?
Yes, sir.
Okay.
Patient may have any breathing difficulty as there is intercostal muscle involved.
No. Don't confuse. Leave it like that. See, the lump is mobile. Don't ask them to take a rampage on you. Just understand this patient has got a lump which is falling forward when you put the patient into a forward bending position. When you do a mobility test along the pectoralis major itself, it is mobile. When it is mobile and not fixed to the pectoralis major, you can't be fixed to the pectorally underlying rib and intercostal muscle. And it is moving with the breast. That point you missed. Is it moves with the breast or moving within the breast? This is moves with the breast. That indicates tumor arising from the breast. Okay. Okay, sir. Shall we ask him to go
why
further,
do you assess for the parasternal resonance?
To look for any internal mammary lymph nodes, sir. If there is an internal mammary lymph node enlargement, there will be dullness.
Which quadrant tumors have more chance of internal mammary?
Inner quadrant tumors.
Nodes.
Inner quadrant tumors.
Even inner quadrant tumors, axillary node is more common than internal mammary.
Exactly.
But only a big enlargement of the internal mammary nodes will be detected by this clinical method. So, what is external mammary node? Quite interesting, no? If there is any name called internal mammary, then there must be some external mammary. Lateral thoracic artery. which is lateral border of present in the lateral borders of vectralis major, commonly we encounter during surgery. That is called lateral thoracic artery or external mammary. That artery and that vein is accompanied by anterior group of lymph nodes.
Okay.
There are many groups of lymph nodes in the axilla, correct?
Yes, sir. Anterior, lateral, posterior, central, and apical.
So anterior group, interpectoral node, or along with the external mammary artery, vein. Okay.
So, Bharat,
Right,
you
proceed.
said this in the examination of the spine, you checks for the no spinal tenderness.
Yes.
You do the check for the tenderness at the spine?
Yes, sir.
Or
By pressing
paraspine?
over both spinal and paraspinal.
You have written both, no? Spinal as
Yes.
well as paraspinal.
Paraspinal tenderness.
You know, where is the metastasis to the vertebra?
Body of the vertebra. It will be to the body of vertebra.
Body of that. And the body where it is?
What is the route of spread?
Maxillus plexus. To the maxillus plexus.
How it goes to the lumbar vertebra? What is the peculiarity of that plexus? Usually venous flow will be unidirectional, no?
Yes, sir.
So Baxton plexus are valveless, without valves. So retrograde spread, especially during intrathoracic pressure increases, like coughing can produce reversal of the venous flow. That is how it goes to the lumbar vertebra.
And it goes to the pedicle of the vertebra, no? That is the place where there is a first metastasis is there. And that is why you always check for the paraspinal tenderness or paravertebral tenderness rather than checking for the spine. No?
Yes.
Okay. Yeah. What other thing you should have examined in the abdomen in this patient? You said no hepatomegaly. And which palpable mass you want to see?
Liver we have to check for hepatomegaly. There may be liver metastasis, so how to check
That
for
you have written, the hepatomegaly you have written.
Yes, sir.
You have written something other also, no? No palpable mass. What is that palpable mass which can occur in the abdomen in a case of CA breast?
Starts with K.
In a woman who is premenopausal age group with a functioning ovary, what can happen?
Krukenberg tumor. Ovary can be.
We can be giving crooked. We can be giving crooked cues, man. You have to pick it up when he says K. Yes. Yes, proceed.
So what are the characteristics of the Krukenberg tumor? What are the characteristics of a Krukenberg tumor?
Yeah, please answer that question.
रिपोर्ट बड़ा हुआ है क्यों? बस मुखड़ा दिखाना है, खाली दिखाना है कि अजय खन्ना सबसे बड़ा
Krukenberg is usually bilateral and completely solid tumor. Ovarian tumors are mostly
unilateral.
solid and cystic component will have. So completely solid tumor,
bilateral solid tumor.
Krukenberg is present in premenopausal woman, functional ovaries, bilateral, and may not be a contraindication for a major surgery. They spread by transcoelomic spread. There is a theory, they say it spreads by retrograde venous spread also. Yes. Okay. You didn't fail to mention one thing on inspection in the abdomen. What is important on inspection in abdomen and CA breast? In advanced CA breast. Sometimes you may have Sister Mary Joseph nodules in studded liver secondaries. Studded liver secondaries, advanced malignancy. Okay. What are the other cancers that can go to bone?
Apart from that, for advanced malignancy, if the patient need reconstruction, you have to see for any scar. If there is any scar, transverse scar, it is contraindication for tram flap. Okay.
Yes, sir.
Am I audible?
Yes, sir. Yes, sir. Very much, sir. Very much audible, sir. What is tramp lab? What is tramp lab, Bharat? Plastic posting முடிச்சிட்டியா?
Yes, sir.
முடிச்சிட்டேன்னா சொல்லு.
Rectus abdominis muscle flap.
Muscle flap. Okay.
So ipsilateral transverse abdominis muscle will be used. So any upper abdomen transverse scar contraindicates for tramp flap. Okay. So locally advanced disease, if the patient wants reconstruction after MRM, so this is an inspectory finding. You have to document. Okay.
Okay.
Yes. Proceed.
So what is your diagnosis on the basis of the history? Provisional diagnosis.
Summary, sir. A 47 years old nulliparous postmenopausal woman, Mrs. Girija, with complaints of painless lump over the right breast since 1.5 months, along with history of significant loss of weight. On examination, she had a 4x4 centimeter well-defined hard lump in the upper inner quadrant and outer quadrant of the right breast, with uneven surface that moves along with the breast tissue, with axillary lymphadenopathy and no clinical evidence of metastasis. So my diagnosis is it's a case of carcinoma right breast with stage of with stage 2B with tumor TNM staging as T. Yes, sir. Yes, sir.
Okay.
T2N1M0 stage 2B, sir.
Will it be a benign tumor of the breast?
Yes. Yes, sir. Actually, it may be a benign tumor of breast, sir. It may be an.
Exam pass kodukka mattaru. You have to give justification.
Yes, sir.
Not for your yes answer.
Because you can't be saying yes to Selvaraj sir and get a pass, man. You have to say why. Bloody fellow, what are there in the axilla?
Sir, node was there, sir, but it may be an infected breast.
What is the consistency of the node?
Hard nodes.
You are digging your grave. See, what are the characteristics of a node in the axilla to be called as clinically significant and clinically malignant? When you say the size criteria, node in the axilla to be significant?
More than 1 centimeter in size.
Very good. What are the size of these nodes?
2 centimeters.
2 centimeters. Okay, they are significant. Then what made you think in terms of malignancy?
Hard node. Hard nodes.
And now you say benign to Selvaraj sir, he will give you left and right.
Say the features of benign findings for lymph nodes in the axilla.
Benign lymph node will be.
Usually they think only the malignancy. They wear a tinted glass to see everything as malignancy. So discuss about the benign conditions. So how do you say it's if a node is benign? When will you call it as a benign node?
Node will be of relatively smaller than a malignant node, sir, and it will be soft to prim. And if it is of infected,
benign node cannot be 3 centimeter size.
It can be.
The infection. So you say painless, enlarged lymph node, hard consistency. No, the painful lymph nodal enlargement associated with any inflammatory infection condition of the breast, that is draining area is having any infection, that will be benign. Okay. And small, without any primary, if you find any just lymph node and it is soft, not hard in consistency, it can be benign. Okay. You cannot label everything as malignant. And what are the features of benign breast lump?
So, firm in consistency.
Symptoms and signs of benign breast lump.
Symptoms, it may be painful, sir. The patient will have pain.
So usually painful swelling will be benign. Yes, next.
And it will be mobile, and it is not. It won't be hard in consistency. Either it will be cystic or firm in consistency, sir.
Or soft.
History wise. See, one tumor is painful swelling, accepted. painless swelling, waxing and waning, increasing in size, decreasing in size, cyclically with the correlation with the menstrual cycle. What is it called?
Fibroadenosis.
Huh? Fibrocystic disease.
Fibrocystic
Okay.
disease.
So hormonal influences, water content of the microcystic spaces will change in size. So cyclical mastalgia, okay, associated with, and increase in decreasing in size, waxing, and so variation in the size depends on the menstrual cycle. It will be benign. Okay. So static disease, 4 years duration, same swelling. Will you call it malignancy?
Static.
So by history,
No,
long duration or painful swelling or increasing and decreasing in size, all will be favoring the benign condition. So always think of benign counterpart, and see, otherwise you will see everything as malignancy. Then you will refer every case to me.
Exactly.
Then, how will you practice?
Sir, as rightly said by sir, the commonest lumps in the breast are benign. Unfortunately, we are seeing with a tinted glass to see everything as malignant. If you take a diary and note, 70 to 80% are benign, and majority of them come to the category of Andy. What is Andy? Sir has put the explanation. You just have to see, expand this. What is Andy?
Aberration in normal development and evolution of breast.
Yes, that's what. In the first 15 years of breast, 15 to 35, the breast goes for evolution. 35 to 50, it goes for involution. So the proliferative diseases are more common in the front half, and degenerative diseases like cyst formation are more common in the distal half. But malignancy is more common in the middle and lateral half. So they are more common lumps, lumpy breast, discrete lumps, regression in size because of cyclical changes. Thank you, sir, having brought this point, because we see more benign lumps than malignant actually.
You are going to see more benign cases. You are going to earn more with the benign cases, not rather than dealing with malignancy. It is common phenomenon. Okay. So then you have to read more about the benign condition.
As long as you are a benign surgeon, you will be making a lot of money with benign
yes,
surgeon.
True.
When you become a malignant surgeon, you will be.
So that obviously incidence is very less.
Very less.
Okay. So you have to see the clinical symptoms, and so symptom-wise longer duration, and postmenopausal, if the size decreases because of hormonal changes, it will be benign, like fibroid uterus or fibroadenoma. Breast mouse will be benign. Okay, so whenever you write a finding related to the malignancy, you have to think about the counterpart. What could be the benign symptom? What could be the signs related to the benign condition? Okay, right. Proceed, please proceed. So, what are all the findings against benign condition in this case? Just repeat the summary.
Yes, sir. The patient has a breast lump of size 4x4 centimeters, which is a hard lump found in the right upper inner and outer quadrant of the right breast, with uneven surface, and uneven surface is a point, sir, and with axillary lymphadenopathy, which is hard in consistency.
Progressively increasing in size.
Yes.
Okay. The same swellings are static for 2 months. You need not to suspect malignancy. It may be a benign. Please proceed. Please proceed.
So investigations I do for this patient. First, the investigations to confirm the diagnosis. I do a triple assessment, which includes clinical examination and radiological examination like mammography, X-ray induced mammography, and HP histopathological examinations like core needle biopsy and FNAC.
Which order you will do?
So first clinical examination, sir. First, then go for radiographic examination. Radiographic examination, radiological examination.
Why not FNAC directly? It will
non-invasive. Sir, once we do an biopsy, the distortion will be, we can't, radiological imaging will have artifacts.
Please repeat. Please
Sir,
repeat.
if we do a
Audio is
biopsy
not.
or FNAC, radiological images will have artifacts.
One
Artifacts
is
will be
artifact, second is discomfort. Mammogram itself big discomfort. They will compress like this thing, sandwich. Then only they can have a thin layer of breast so that the quality of mammogram will be better. So it is a painful procedure, X-ray mammogram. So one thing is artifact, second thing is discomfort. After doing FNAC or true biopsy, patient will not tolerate mammogram. And always non-invasive first, then invasive. But false positive, false negative with tissue diagnosis. Should be first.
Hello, sir.
Hello.
What is the appearance of cyst in X-ray mammogram?
What is the appearance of? Sir, can't hear. Pardon me.
What?
Hello, Bharat.
Yes, sir. Yes, sir. I can hear you.
I'm not able to hear. There is some disturbance. Sir, please repeat your question, sir.
What will be the finding in X-ray mammogram of a breast cyst? It will be radio opaque.
Fully radio opaque.
Yeah, fluid will be more radio opaque than the fat. Okay, right. Please proceed.
Yes, sir. So the mammogram of the patient reports, the X-ray mammogram shows an hyperdense area noted in the right upper breast and right breast upper outer and inner quadrant. Enlarged node noted in the right axilla. And UST mammogram, lobulated lesion measuring 3.7 cross 3.6 centimeters from 11 o'clock to 1 o'clock portion of the right breast with the specks of calcification. Enlarged node with increased cortical thickness measuring 1.6 cross 1 centimeters. This is a mammographic image.
Ultrasound finding favoring for lymph nodal metastasis. What will be the finding?
Increased cortical thickening.
Loss of fatty hilum. Loss of fatty hilum. Increased cortical thickness may be seen with infection also, hyperactivity. Okay, but destruction of the hilum, loss of fatty hilum is very peculiar for malignant deposit in the lymph node. And the second thing is transverse diameter will be more than the longitudinal diameter, and always size criteria of the node by imaging is we are taking the short axis, not the long axis. Generally, you measure all the tumors in the long axis, you will compare and this thing, but lymph node, the short axis is the criteria to say whether it's significant node or not. That is why if you see rounded node, that means malignant node, correct? Oval node means benign node. So short axis enlargement is considered as malignant deposit. In infection, it will be uniformly enlarging. So oval shape will be maintained. Short axis will be lesser than the long axis. So if the short axis is bigger, then consider it's a malignant deposit. Please proceed.
The mammographic image of the patient. And we did an FNAC, sir. The FNAC of the right breast shows features suggestive of ductal carcinoma. And we did an FNAC of the right axillary lymph node, sir. It shows smear positive for malignancy, metastatic carcinomatous deposits in the lymph node, sir. And then we did a true biopsy for the patient, and it shows section positive for malignancy. And we did a repeat biopsy for hormonal receptor status. The report is yet to be available.
So usually true true-cut biopsy will say the subtype of the malignancy, and just positive for malignancy means the tissue submitted is very scanty, or sampling error is there. So the gun fired at the periphery of the tumor. Okay. So always aim the center of the tumor to fire it. If it is a very small tumor, less than 2 centimeter, don't use true-cut biopsy. Because firing range is 2.5 centimeter in the firing range. That is inner tube, outer tube movement will be 2.5 centimeter for any common true-cut needle. So anything less than 2.5 centimeter always plan for FNAC, or if you have doubt, do excision biopsy. More than 3 centimeter, you can easily do true-cut biopsy, right? And show me the FNAC report. Some this report is right, but some reports say infiltrating ductal carcinoma. Over enthusiastic pathologists like you. So infiltration cannot be commented on cytology. For to declare it is infiltrating, there should be a basement membrane seen in the toe, but it will not be there in cytology. So you have to see the basement membrane, and the infiltration of the basement membrane, you consider it is a infiltrating ductal carcinoma. Otherwise, ductal in situ malignancy. Okay, DCIS. So any FNAC says infiltrating ductal carcinoma, don't believe in the diagnosis. So it see a 2 centimeter lesion. If it is a ductal carcinoma in situ, will you do axillary node dissection?
Ductal carcinoma 2 centimeters.
You need not to do it, no, because lymphatics are below the basement membrane. Okay. So if the tumor does not reach the basement membrane, it will not reach the lymphatic channel at all. So past lymph nodal metastasis is less than 1% in ductal carcinoma in situ. So not differentiate ductal carcinoma in situ infiltrating ductal carcinoma. So cases ductal carcinoma in situ in final diagnosis, you are doing axillary dissection, that is overdoing. Without justification, you have done it. That is why the FNAC is out of vogue. Most of the surgeons prefer true-cut biopsy. Okay. And true-cut biopsy, even you can get IHC study, which cannot be done in FNAC. So ER-PR status, triple negativity. Triple negative disease is very bad prognosis. So most of the tumors are treated with complete total neoadjuvant chemotherapy. That is, we give all 8 cycles before the surgery. Okay. So that is the current concept. So we always prefer true-cut biopsy rather than FNAC.
Okay, what do you expect it to be a common tumor as in histopathology? What is the commonest breast
common pathology?
Common histopathology in breast malignancy.
Subtype. Common subtype.
Subtype.
Luminal.
No, not IHC. Pathology.
Pathology, ra? I'm asking that which is common, ductal or lobular?
Ductal carcinoma. Ductal carcinoma.
What
ductal? NOS.
What is in ductal?
Ductal carcinoma, otherwise?
Not otherwise
specified. Not otherwise specified. Yes.
What are the other subtypes? You know. Medullary, capillary,
atropic serous and colloidal carcinoma and tumidol.
Colloidal carcinoma has good prognosis or bad prognosis?
Colloidal carcinoma, bad prognosis. Tubular as the good.
No.
Colloid carcinoma of the colon and the stomach are bad prognosis. Exactly. Colloid carcinoma of the breast has better prognosis than common.
Thank you, sir.
Point.
I usually bring in the same point in discussion.
Otherwise, I will not ask.
Anywhere mucin is there is bad prognosis. The only area where colloid gives a good prognosis is in breast. So this must be highlighted. Anywhere we see mucin, we say bad, especially colon and rectum and stomach. But we in breast, it's the not otherwise specified is the worst breast cancer. All the special types of breast cancer have got good prognosis. Very simple time. There is no differentiation to any cell line in not otherwise specified. In special types, there is differentiation to a colloid. There is differentiation to a tubule. There is differentiation to a papillary. There is differentiation to a trabecular pattern. So there is an attempt to form tubules. So they carry a better prognosis. NOS carries a poor prognosis. Okay. Right, proceed.
Please proceed.
What will you do? The diagnosis has come. We have sent it for receptor status. We have not received it. Take it for granted. So you just say luminal A. Suppose if you have got HER2-1, you have got ERPR, HER2 receptor study also positive. How will you classify the breast cancer? What is molecular classification of breast cancer?
Luminal A, luminal B, and basal subtype, peritoneal positive status.
Okay. I think yes, read, sir. So we'll skip this.
Yes.
We will skip this. Then what will you do? Once confirmed, it is not.
What is comido? You said comido.
Comido?
What is comido? Where do you get comido type? So that is subtype of in situ malignancies. This is invasive malignancy. We discussed about the invasive malignancy. Okay. There is a subclassification for the in situ malignancy. Please read tonight. Okay. Right.
Right. After confirmed
Please
it is
proceed.
malignant, what is the next stage of your workup?
Sir, next we have to look for any metastasis.
So diagnosis confirmed. Next step will be?
I have to look for metastasis, whether there is any metastasis.
So metastatic workup. So confirm the diagnosis, then stage the disease. This
Stage
is
the
the
disease.
order.
Yes, sir. So to stage the disease, I will do an ultrasound abdominal pelvis to look for any abdominal metastasis, and X-ray chest to look for any lung metastasis, and a skeletal survey to look for any bone metastasis.
Will you do CT chest, PET CT scan for this patient? Will you do CT scan, CT chest for to rule out lung metastasis? Will you do PET scan for any distant bone metastasis?
Otherwise, what are the indications for doing a PET scan? Is a direct question. Indirectly, sir is asking you. Tell me what are the indications for?
So you do metastatic workup basically with the chest X-ray and ultrasound abdomen, skeletal survey. That is enough. Okay, but symptomatic stage, asymptomatic stage 1 and 2, this is enough. Okay. Asymptomatic, that is no symptoms of distant metastasis. Symptoms of metastasis. Okay, like back pain. No back pain, no need for any evaluation. Like that. Okay, so asymptomatic stage 1 and 2, simple metastatic workup. But symptomatic stage 1 and 2, if she has breathlessness, cough, headache, back pain, bone pain, then go ahead with detailed metastatic workup. For stage 3 and 4, even without symptoms, you have to do complete workup. Either do bone scan, then CT chest, CT abdomen pelvis for ovarian metastasis, liver metastasis, or one go you do PET CT scan. Everything will be done by one scan is PET CT scan. So asymptomatic stage 1 and 2, simple metastatic workup. Symptomatic and 1 and 2, asymptomatic 3 and 4, you have to do detailed metastatic workup. Okay, please proceed.
Other investigation to assess the patient for surgery, sir. You do a CBC, RFT, and ECG blood sugars, total protein bleeding time and clotting.
So you will not discuss for breast conservation. You will decide by yourself to remove the breast. You have to give option of breast conservation and is there any survival difference between breast conservation and MRM?
No, sir.
Is there
No,
any
sir.
survival advantage of doing MRM?
You can always say almost nil.
no,
That's
sir.
the
So
best
it is
reply you can do.
equivalent to do both. Okay, so give the
Yes, sir.
choice to the patient.
Yes.
If she says MRM, she is willing for MRM, or if she says breast conservation surgery, then accordingly you have to proceed.
Yes, sir.
You cannot decide for her. Okay, it's a mutilating surgery. Will you do surgery for this patient without biopsy?
No, sir.
I will do. Without biopsy, you can do breast conservation surgery. That is not mutilating surgery. But for MRM, you need a definite tissue diagnosis. Because breast conservation surgery, you are going to do wide excision.
Wide local excision. Yes, sir.
Wide excision, axillary dissection, followed by radiotherapy. But before
Radiotherapy.
radiotherapy, you have to get tissue diagnosis. You need proof of malignancy. What are all the malignancy? You will not require tissue diagnosis before surgery.
Testicular cancer.
Okay, you are diagnosing with tumor markers and doing it. Anything else? Liver, pancreas.
Pancreas.
Those tumors producing needle tract malignancy, highly virulent
Yes, sir.
tumor, needle tract malignancies are common. So without tissue diagnosis, you can do. CA ovary. Yes, you need not. You should not do biopsy in CA ovary. Okay. So for any mutilating surgery, you have to have tissue diagnosis of malignancy. Okay, right. Please proceed. Please proceed.
Yes, sir. Treatment plan for this patient. I have to discuss with the patient.
So she is willing for modified radical mastectomy, and you are proceeding with MRM. Yes. Yes, proceed.
Yeah. What will you do after doing a modified radical mastectomy? What will you do?
What modification you are doing?
Radical
Who did the radical
mastectomy.
mastectomy?
Yes, sir. In radical mastectomy, the pectoral is major.
No, what is the name of the mastectomy which we are doing?
Who did the radical mastectomy first?
Alstead, sir.
Alstead. What was the next modification?
Next modification is Patty's modification.
That is modified radical mastectomy. Okay. What is the modification in Patty's?
Patty's, in Patty's, we are dividing and removing the pectoralis minor.
What is the modification he did? What is the difference between Halsted surgery and Patty's surgery?
In Halsted surgery, the pectoralis major, pectoralis minor, and the serratus anteriors all were removed, sir. They were preserved in
what was the original surgery? You know, he will remove the skin of the same ipsilateral.
So,
yes, sir. I think you can.
Others would like to.
Yes, sir. We can close, sir.
I would like to give the final comments, Dr. Kanna, sir. Ratna ma'am, are you with us?
I think it's almost time, sir. Probably everyone is gone.
No,
Sir,
sir.
one
They don't go
important,
without her. Yes, sir, please,
one important missing thing was role of MRI.
Okay.
Because increasing trend of breast conservation therapy, role of MRI must be known to every postgraduate student.
So you can give a quick sum up, sir, please.
Yeah.
MRI, indications of MRI.
Indications of MRI. MRI can be done previous breast surgery. Patients who have undergone previous breast surgeries, patients with breast implants and breast carcinoma in younger females and breast carcinoma in pregnant women, we go for an MRI.
What is the implication of kinetic curves in MRI? What is CE-MRI? Contrast enhanced MRI. What is it? And what is the implication of kinetic curves?
Maybe you can give the answer, ma'am.
Yeah.
completely.
So you have to see how rapid is the take up and the washout of the contrast. Based on that, there are 3 kinetic curves. And type 3, in which there is a persistent rise, is suggestive of malignancy. First one, there is rapid uptake, rapid washout, then rapid uptake and a plateau. And then if there is a rapid uptake and it continues to be persisting, that is a type 3 curve. What is abbreviated MRI? So in abbreviated MRI, no, this is being done more frequently. You don't do it in a delayed phase. Right? And in reconstructions, you need to know a little bit about the perforator flaps also, especially the free perforator flaps in cases of upper inner quadrants. Yeah. Well presented.
Thank you, ma'am. Thank you. Tiwari sir, any inputs more for this MRI, sir?
One important input sometimes in inflammatory breast carcinoma or filariasis also. It can be very confusing sometimes. Even FNAC true cut may not be informative. In that situation, MRI may help. So that is also considering our tropical setups where breast filariasis is also encountered. MRI must be practiced in that cases.
Perfect, sir. Perfect. Indeterminate diagnosis, especially benign versus malignant and inflammatory versus malignant. Point is well taken, sir. And the curves
Even,
like, sir, yes, sir, please, sir.
even tumor is not palpable, but there is a strong doubt of malignancy, then MRI comes in action.
Yes, sir. Sure, sir. Sure. Point is taken, sir. Ambrish, I think you should spend time how you inform or look for SUV in PET CT, MRI, these 3 different type of curves, role of contrast and timing of the MRI, the dynamicity. They go for dynamic MR. And the most recent one for the benefits of students as recent advances, the fibroscan. Gautam, can you please mute yourself? The next important thing will be the fibroscan. So fibroscan is also being experimented. Few early publications have started coming in. They are trying to bring in the amount of fibrotic activity versus the tumor response. Because which patient qualifies for neoadjuvant is the most important thing. Because there is a certain element of patients who may not respond to neoadjuvant. So those areas are the one newly being researched with modern tools. So that you please spend time on that. Non-responders to neoadjuvant therapy, you should be able to tell out few important things. Whether you will be able to prognosticate who will be a good responder and who will not be a good responder for neoadjuvant therapies. So those areas, imaging, they are trying to get into the radiomics component into it for stratifying that patients who are going to be benefited or not. That is one thing. And the most important thing, as breast conservation is taking into a more robust thing, almost up till T3, now they claim breast conservation can be done. That is where MRI helps you to clearly mark the parenchymal clearance, how much you want to give. And also, the oncoplastic surgeons will be able to plan the type of flaps what they are going to use, LD flaps or anything, because they prior to know how much of defect is going to exist after the BCS. So a lot of volumetric and physical measurements are possible with more newer imaging. Those are the things which are the recent advances, which I recommend you people go and read. The omics component is definitely going to be a short note or some form of question, because a lot of exciting things are happening, because it is trying to do a biological imaging. That's the right word. Or from the time of metabolic imaging, we are moved to more sub-receptor based imaging, and the physicochemical characteristics of tumor also more studied to ascertain the prognostication. I think that covers up anything. Other faculty, do you have anything left or anything like to add? I think Mehta sir has left. Arasa sir, you can give the closing comment. Sir, Mehta sir, please. Sorry, I missed you.
No, sir. Thank you. I have only 2 comments to make here. First is the epidemiology of the Indian breast cancer. It is quite different from Western breast cancer. Our female are getting breast cancers at younger age, 48 versus 63. We are getting triple negative more frequently, 40% versus 15%. We are getting LABC or metastatic cancer almost 40% compared to only 25% to Western world. So, and few more things. Most of the time in India, we end up in getting MRM, even in early breast cancer. 98% of the surgery done in India are MRM. That is almost 50% in USA for early breast cancer. The importance of this epidemiology is the fact that the screening program, which we have not, our government has not been started here because the incidence is low. 16% of the female belongs to 30 to 40 age group. How we are going to screen them? Do we have enough MRI machine? Do the MRI machine does the job for screening this large population? Is it possible to do? The expense, claustrophobia, MRI has its own problem. So we need investigation which can be done. Mammography, it's not good in this younger age group. So we need investigation. One thing, just sir, you told is fibroscan. There are few more things which is still there under validation. Still they are not being validated. But India need them more than anything anywhere in the world. One more thing is the mammography, which he has shown. There are two things I want to highlight. You have to see for microcalcification and architecture distortion of the tumor. And third thing is the distance between the tumor margin and the skin. Now that is very important in deciding the BCS and whether you can spare the skin or not. There are a few more things, but I think time is it's almost 10:30, so I'm not going to go in too much detail. These two things I want to emphasize. Thank you.
Thank you, sir. Thank you. Arasu sir, your closing comments, sir. I think you have prepared the student. Sir, you are in mute mode. Sir, please unmute yourself.
Sorry, sir. Sorry,
Yes,
sir.
sir.
Accidentally, I put it in the mute mode. It is not.
Yes, sir. We
Sir,
are
thanks.
talking for some. Yes, sir.
I thank you very much, sir. I thank Kanagavel sir for giving us opportunity. And it better to be a spectator to make others question my students so that he exposed to a literal virtual examination. And they are all second year students, sir. Actually, they're not final years. We'll try to do the best, sir. Thank you very much, sir. Valuable comments. Every teaching session is a learning session for us also. So we learn from others all the time. And a lot of things which I have learned, and I've been thanking all of you on behalf of my student and from my side for making this a learning session for me too. Thank you very much, sir.
Thank you, sir.
Because I start asking the questions, it becomes a repeat of what is happening every day in the ward. Instead, let others ask questions. And I also get the idea where we are lacking or which direction we should concentrate. Probably so radiology and other things we need to concentrate. Thank you, Ambarish. Thank you, Ambarish, for this presentation.
Thank you for that.
Thank you, sir. Thank you, sir. Thank you all, sir.
Thank you.
And good
Thank
night.
you, esteemed faculty. Good night, everyone. We will meet next Friday with a different case. Selvaraj sir, thank you. Any other comments? I missed you. I thought you have left. Anything else, Dr. Selvaraj?
No, sir. I just want to wish both the candidates, they did well, and my best wishes for them. Thank you.
Thank you. Thank you, Dr. Selvaraj.
Thank you, sir.
Very
Thank you,
much.
Selvaraj, sir. Wonderful
Thank you, sir.
having you on the platform. Thank you, sir.
Thank you, sir. Thank you, everyone. Good night.
Good night, sir.
Good night. Good night. Good night.